Hi everyone, I'm Amy Haynes. I'm the Cancer System Innovation Manager for Illawarra Shoalhaven Local Health District, and with me is Dr. Les Nasser, one of our radiation oncologists in our service. Les and I are going to talk today about a journey we've embarked upon in our district with our multidisciplinary teams, from MDTs to tumour programs. There's a lot of work going on around the state and obviously interstate as well, with MDTs in different forms. And as local health districts, we do different things well, I think. So I think in that context it's helpful to share what's working and what the challenges are. So our presentation today is about the journey towards a tumour program. We're going to share what we've done so far and we'll be candid as well about what we've learnt in the process. And I'll hand over to Les to give some context about the work.
Thanks, Amy. So in terms of cancer treatment, we know, I might just forward that a bit, thanks. So we know that cancer is quite a complex disease. There are many different cancers as there are organs, in fact. And the treatments generally span surgery, systemic therapy and radiotherapy, but these treatments are often sort of combined, and there are new studies that refine the use of these treatments and the scheduling of these therapies. And we know that patients also vary in their ability to cope with cancer treatment. So just in a global sense, cancer is a pretty complex undertaking. Coming to the sort of national setting, basically this sort of diagram here is not meant to be understood because nobody understands healthcare in Australia because it's really fragmented in terms of funding and responsibilities. So that adds a layer of complexity in terms of trying to treat our patients, both in the public and the private system. If we go to the local setting in terms of the Illawarra Shoalhaven Local Health District, so we're a 250 kilometre strip just on the south of Sydney, and there is a skewing of the population to the north and also in terms of resources. So we do have challenges in terms of the equity of the access to multidisciplinary care, and that's why we were interested in the telehealth initiatives. So when I first started, which was around 2000, we basically didn't really have formal MDTs. Basically, treatment was often delivered without subspecialist input. The treatment itself was carried out often in isolation, and there was little contact between the peers, and outcome data essentially was either incomplete or non-existent. And added to that, there was the communication issues in terms of primary care physicians. So we know that there is a body of evidence that MDTs do improve care. Most of that data comes from breast cancer. The ideal is that best practice is adopted by adopting evidence-based guidelines, and that is facilitated in an MDT environment. Basically, the MDTs allow streamlining of treatment pathways, and it does quite often shorten the time from diagnosis to treatment, and also access for clinical trials. So in terms of the future role of MDTs, we see it as and not just us, but it's seen as a way to improve quality and standardisation of care, and an ideal structure for clinician-led system improvement. So in 2008, the colorectal cancer MDT was established, and actually that correlated with the arrival of 3 very keen surgeons. The radiation oncologists and the medical oncologists were around, but when the surgeons came, we thought it was a good time to try and get together. So in terms of the issues that we encountered once we first started was often the incomplete information that was being populated on the referral forms. That includes the clinical features, pathology and imaging. So often that was lacking. And we know that if you try and make decisions on incomplete information, you're just going to get basically wrong decisions. And there were issues with meeting mechanics and dynamics, just the way the meetings were discussed in terms of, I guess, efficiency, that sometimes meetings can be dominated by loud individuals or people who don't necessarily want to speak up but have an important contribution to make. Also, we weren't really getting data for KPI indicators. So we surveyed actually Amy came up with the idea of surveying the members about, what they thought were the problems. So we got quite a few, so these are some of the actual text that was put into the, I think it was a SurveyMonkey that we used. So, some of the things that were said, I'll just see if I can, that MDT discussion not warranted for straightforward cases, management by the lead clinician or the use of protocols is sufficient and sometimes preferable. So people wanted to select which patients they wanted to put in. Group dynamics, so that's what I was talking about, extroverts and introverts and people sort of wanting to tell jokes and things like that, and that's not really why we're there. 86% of the members supported the introduction of a mosaic-based meeting record. And there was strong support for collecting data and benchmarking our outcomes and looking at unwarranted variation in treatment and the diagnostic process. So essentially, just to summarise, we wanted a meeting record based on our electronic system. We wanted formalised referral criteria for selection of patients for discussion, because often our meetings are second weekly, and so often we don't have time for every case to be discussed. This is my sort of bugbear, clarification of the roles for the chairperson and MDT members, and systematic follow-up on MDT recommendations, and working towards measurement of outcomes and reporting of data to the group.
Thanks, Les. So just to talk about our approach, once we had our priorities, we formed a small project team, and then we asked the MDT for volunteers to join us in the work. And we got 2 colorectal surgeons, one is the MDT chair, a medical oncologist and a radiation oncologist, which is Les. And we use this group as our core consultation and guidance group. We meet with them about once a month before the MDT meeting. This is a picture of us at one of our meetings. This group is a really important source of advice, but the other thing we're doing with that small group is building up a joint understanding and commitment to the work that we're doing, so that each time we take a piece of work to the broader MDT, these core members can advocate for it and talk to their peers in other specialties as well. And the other thing we're doing with our colorectal MDT, we're working with this group because they're really willing and going to try and use that as a proof of concept. So partway into the project, we had multiple strands of work happening simultaneously, and we started to feel the need for some kind of guiding structure. In part, that was because we needed to be able to distill a complex set of goals into something we could explain and that people could understand. And at this point, I want to specifically acknowledge Kylie Museth and the team at Nepean, who shared their accredited tumour program ideas with us, and that was a very helpful reference in developing our framework. So I'll introduce the individual elements of the framework and then talk a little bit more detail about them. So patients managed by this team receive evidence-based care. Patients are discussed and managed in a timely and efficient manner. The team works together effectively to maximise multidisciplinary input. The team communicates about the management of the patients with all the relevant stakeholders. The team measures outcomes of patients under its care, and the team actively promotes education and research. And if an MDT is doing all of these 6 things, it's no longer managing individual patients in a meeting. It's effectively overseeing the care of a cohort of patients with colorectal cancer in the district, and that's our vision for a tumour program. So evidence-based care. Over an 18-month period, we developed a model of care for patients with colorectal cancer, which outlines the ideal management for for patients in our district. It was a hard slog, and these are the people in the pictures who brought it into being, some of our CNCs and our nurse practitioner. As you can see, the model steps through all of the key points in the patient journey. We've done a district model of care for lung cancer as well, and both the lung and colorectal models align with the Victorian optimal care pathways. So in addition to the model of care, we're looking to have the MDTs explicitly agree on detailed management pathways for patients with early stage disease, patients that don't necessarily need to be discussed in an MDT meeting. Which leads me to element 2 of the framework about timely and efficient management of patients. So the MDT developed a set of referral criteria. This is it here. So patients are categorised according to their diagnosis and allocated a priority for discussion in the MDT meeting. So for example, category 1 in red is for patients who need urgent discussion. That includes all new rectal cancers and anal cancers prior to treatment. Category 2 in orange is for discussion in the MDT meeting, and category 3 patients in green are patients who have early stage disease and whose management is via those evidence-based pathways endorsed by the MDT. So these patients are not discussed at MDT meetings. We've done referral criteria for 2 MDTs now, and for both it's been a really valuable thing to do, not just for the outcome of actually having the referral criteria, but for the process of consensus building. It has given people a neutral platform for discussing the subtle variation in practice that always exists. And in the colorectal MDT now, you hear people referring to our criteria, and I think that's a positive thing, that there's some group ownership of those sorts of things. We've also redesigned our MDT referral process, and in the colorectal MDT we now use a PDF fillable form, referral form, which is available online and can be used on any device. As Les mentioned earlier, one of the most important priorities in our MDT work was to start recording MDT discussions in Mosaic, and in order to do that we needed to have better information provided on referral. So it looks a little bit demanding, but actually it's very easy to complete. A lot of those boxes are tick boxes. Just a couple of things I wanted to point out in the referral form. So there are some fields in there that are key fields that the Cancer Registry needs and finds it very difficult to get in any other context other than MDTs, like the date of surgeon consult in the private sector and the ECOG score, so they're in there. There are the triage categories from the referral criteria in there too, and when the patient information comes in there, the MDT agenda is organised according to those referral criteria categories. The other new addition is the clinical question at the bottom of the form, and this was a response to comments in the survey about sometimes rambling, unfocused discussions. And this field is really well filled out. Over 90% of referring clinicians fill it out, so obviously they find that valuable. And those clinical questions are then on the agenda as well for the MDT, so they help to structure the discussion. Then we have the buttons up the top here, so when you click the submit button, it goes automatically through to the MDT coordinator, and then the clinician can clear the form and start again for the next patient and submit it. And in future, we're going to try and work towards using the Prosaic platform, which is the platform that we're currently using for our prompt patient-reported outcome measures, so that this information can be populated in the PDF form and then auto-populated into Mosaic. So we're going to work towards that. So all the resources I've talked about so far are on our website under the Health Professionals tab. This is the colorectal MDTs page, and we're going to put some nice member profiles on there in the future, and we plan to do one of these pages for each of our MDTs. We also have easy access to imaging in MDT meetings through the use of IntelliViewer, which I know a lot of other districts have as well. And we use IntelliViewer on our Citrix platform, so it's available to all clinicians everywhere. And you can access all of the local imaging providers from it. So the Mosaic MDT record, and it was very interesting to hear Brett from Queensland speak about what you've done up there, and I think you've probably made a very valuable contribution to MDT workflow up there. I think all of us were looking at it going, wow, that's really good. You've obviously got a more advanced version of Mosaic as well. But that was one of the highest priority improvements nominated by our MDT members. So ours is an assessment in Mosaic as well, which means we can mine the data from it. So we have a set of data on every patient referred to the MDT, and much of it is pre-populated prior to the MDT meeting from the information on that referral form I spoke about. Pre-populating the assessment is really important so that it's a workable document in the meeting, and one of our registry data managers currently pre-populates that assessment from the referral forms. And the thinking behind that arrangement is that the MDT assessment gives our service and the registry access to a really complete and contemporaneous set of data about the patients we have. It's a different kind of role for cancer registry staff to be working with the clinical teams and engaged in that clinical workflow, but I think it's already having benefits for the quality of data that we get. So a registrar scribes into the Mosaic assessment live in the meeting, and this is projected on a screen for everyone to see. And I think as well, Brett sort of questioned the value of, questioned people's obsession with seeing live data entry, and I think it is actually a very valuable thing because clinicians can check what they're saying is being recorded accurately, and they're really keen to do that. They're also keen for dissent to be recorded accurately as well, and I think it makes everyone more accountable for the comments that they make when they can see them being recorded. And lastly, one of the findings in our MDT survey was that the length and quality of discussion in meetings sometimes vary between patients. So one role of the Mosaic meeting record is to add some structure to that discussion as well. So working together effectively. Les talked about dynamics in the team and the way this impacts on discussion in meetings and ultimately on decisions that are made. So our response to that has been to do what we're calling a terms of reference document. Really talks about the roles and responsibilities for everyone in the meeting in terms of the standards of conduct, in terms of working together, as well as the requirements for making the meeting work well, like coming with a clear clinical question. Also the role of the chair in eliciting contributions from all of the disciplines present, including, importantly, the discussion this morning that we had about the contribution of psychosocial professionals, and that's where we need leadership from MDT chair people. We want to improve systematic communication from MDTs about care planning, particularly to GPs and then potentially to patients. And when we upgrade to the new version of Mosaic, we'll be able to auto-generate QCL straight out of Mosaic, out of the assessment. And we'll, as Brett alluded to in his presentation, we'll be working on improving systematic documentation that comes out of that assessment. So this element is about measuring patient outcomes. It's something a lot of services struggle with, including ours. But it was something the MDT really strongly supported building our capacity to do. And measuring true outcomes is hard, so we're starting with small steps. Firstly, by building up a culture of reporting back the data that the group is collecting. This is a report we've recently developed which just contains the data from the e-referral form. And with this, we're trying to do a couple of things. So firstly, show the MDT members that what they can get back from the information they're putting in. And we'll do a similar thing in the next few months with our Mosaic assessment too. And the data on the left-hand side is basically just a very basic patient profile. And secondly, we need to improve their compliance with filling out different parts of the form. So you can see ECOG here. This is the blank rating of ECOG, and we're trying to do some education about ECOG. And in the longer term, we want to work towards measuring some of our proper outcomes in a structured way, and we're considering the possibilities of using the ICHOM standard sets and investigating what that could mean. And finally, actively promoting education and research. So feedback from our breast MDT was they wanted systematic education built into the MDT structure, which we're going to be doing. Promoting patient access to clinical trials through MDTs and bringing together clinical trials in the private and public sectors in our region for the benefit of our patients. Facilitating easier access to data, which I've talked about, and promoting tumour banking as well. I think MDTs are a very important sort of lever for promoting tumour banking, and future possible formalised concert links for us too. And I might leave off there, Karen, because I'm scared of you.
Don't be scared of me. I can be a bit scary. Thank you very much. I just wanted to give... Yep.